Hi, good afternoon, and welcome to Sleepless in Boston. I don't know if you're feeling it. I'm definitely feeling it, so we're going to start this off by a nap time. So this is a session I'm incredibly excited for. You'll be hearing all about the amazing advances in sleep research that have been happening here at Harvard and at Brigham. And I think you really are in for a treat. We have three exceptional panelists here. We have Susan Redline, who is the chair of the panel, and she is going to be talking about a very different sort of approach of sleep medicine, which is very patient-centric and epidemiologically centric, and thinking about how entering patients into the equation changes the research and changes the types of questions that you ask. And she directs the programs in sleep and cardiovascular medicine and sleep medicine at Brigham. We'll also be hearing from Frank Scheer, who will be talking about questions of your rhythms, the circadian rhythms, how that interferes with different parts of your life, both internally and externally when something goes wrong. And Dr. Scheer is the director of medical chronobiology program, and he'll be talking a lot about the circadian misalignment. And finally, we have Charles Czeisler, who's been researching sleep for over 4 decades. Is that correct, Dr. Czeisler? Since he was a child. Since his earliest sleep disturbances at age 2, he has been thinking about directing sleep research. And he'll be talking about sleeplessness in Boston and the world over, and basically the huge problems that we have with a lack of sleep and what that's been doing to society. And Dr. Czeisler is the director of the Division of Sleep Medicine at Harvard Medical School and the chief of the Division of Sleep and Circadian Disorders at Brigham. And I'm not going to take up any more time because each of the speakers has so many wonderful things to say. And we'll be starting with Dr. Scheer.
Welcome, everybody. Good afternoon. Maria, thank you for that kind introduction. And it's a great pleasure to be here, speaking to many colleagues I haven't seen yet, because we're all from Brigham. Today I want to take a brief glimpse back in time. So since the beginning, since about 3.5 billion years ago, life on Earth has been exposed to day-night rhythms in light and dark. And this is due, of course, to the rotation of the Earth around its axis. And life is adapted to this, and here's just one example of a heliotrope plant that opens its leaves during the day and closes them at night. And about 300 years ago, there was a French astrophysicist, Jean-Jacques Dortoux-de-Meyrin, who stopped the Earth, at least from the point of view of the plant, by placing it into continuous darkness. And what he observed was that the plant continued to open and close its leaves with a rhythm of about 24 hours. So this virtually was the first demonstration or evidence for an internal body clock existing in living organisms. But what is the underlying mechanism? Now we have to travel in time a bit more closer to now. So about 40 years ago, it was started to be unraveled what the molecular machinery was that underlies circadian rhythms. And what underlies is a transcription, translation, feedback loop that takes an amazing 24 hours to complete. And then it shuts itself down and the cycle starts all over again. And about the same time, 40 years ago, it was discovered that in mammals, the central clock, the nucleus that controls circadian rhythms, is located in the suprachiasmatic nucleus in the hypothalamus. And for about 20 years, it was thought that this is the only real clock that we have in the body. But then about 20 years ago, it was discovered that virtually all the cells in our body, in our liver, heart, vasculature, contain the same molecular machinery that enables these cells cell autonomously to generate 24-hour rhythms. And so in effect, we have trillions of cells existing and functioning in our body. So why care? Why are you here? You don't want to hear me talk about the history of circadian rhythms. Why care? What is the potential relevance of circadian rhythms? And here are just 4 examples. We know that shift work is associated with adverse health effects. We know that there are day-night rhythms in glucose tolerance, so how well can your body cope with a glucose load when you eat something, a sugar load? Might it be that not just what you eat, but also when you eat has an influence on our health? And finally, about 6 years ago, there was a discovery of a circadian-related gene that is a novel diabetes risk gene. So there's a number of examples I'll very briefly touch upon. So shift work has been associated with increased risk for obesity, diabetes, cardiovascular disease. And these effects cannot be fully explained by differences in socioeconomic status or lifestyle. These are based on epidemiological work. But what is the underlying mechanism then? So one of the possible mechanisms we looked at was the role of the circadian system and its disruption. And here is an artistic impression of what one may envision happens to your body clocks when you're exposed to a very erratic light, dark, and sleep, wake, and feeding, fasting cycle when you're doing shift work, or even when you are experiencing jet lag. So in order to study whether this might be having adverse physiological effects, we had subjects in highly controlled in-laboratory studies undergo misalignment, so misalignment between the behavioral rhythms and the internal body clock. And what we observed was that glucose tolerance, and you can see that here on the left-hand side, glucose tolerance was greatly decreased. So the same individuals exposed to similar meals in red showed much higher glucose values, and this is a risk factor for diabetes. And in fact, we found that a subset of the individuals showed values of blood sugar that were consistent with a pre-diabetic status. What about day-night rhythms, daily rhythms, and glucose tolerance? It's been known for a long time, and this is classic work by a group from F and Kauter. It's been known for a long time that when you eat the same meal in the morning and the evening, it doesn't have the same effect. And indeed, in the evening, there is relatively impaired glucose tolerance, as you can see here, by this higher glucose excursion. But what is driving this? Is this due to the fact that we've been sleeping and fasting overnight following breakfast? The response is so much different. Or might there also be a role of the internal body clock? And of course, there are many differences based on the behavioral cycle that are different in the morning with breakfast and the evening with dinner. So before the breakfast, you have been sleeping, hopefully. You've been having extended overnight fast. You've been in the dark and you've been at rest. Well, before dinner, the reverse happens. So you will have been awake for a long time. The fasting duration will have been shorter if you have had lunch. Activity levels during the daytime are higher, and exposure to light. So in order to study this, we again did a different study, brought people into the lab and had them undergo a simulated night work protocol, comparing it to a simulated day work protocol, all within subject comparison. And this protocol was run by Christopher Morris, who was a postdoc in my lab and then became instructor. And what we observed was, again, as you have seen just before, is that the same meal following dinner led to a much higher excursion of glucose, so relatively impaired glucose tolerance, which of course is very similar to what I just showed you. So this was no surprise and what we would expect. And it also paralleled with the pancreatic beta cell measure that we had. So we looked at early phase insulin release, finding that the same meal results in a much higher release of insulin to the bloodstream, allowing the glucose to be incorporated into the tissues much more readily. The surprise, and this again was no surprise, the surprising or the novel aspect was what happens when we now have people invert their sleep-wake and feeding-fasting cycle by 12 hours. If, in fact, the behavioral cycle is driving this difference, then we would expect, again, at dinner time, glucose to be higher and breakfast to be lower. That's not what we found. We actually found the inverse. So now it was that breakfast, the glucose levels were higher than in the dinner, indicating that this is primarily driven by the circadian system, not by the behavioral cycle. And the same holds true for pancreatic beta cell function. Okay, what about meal timing as opposed to what we eat when we eat? And to address this question, in collaboration with Marta Garaulet, who is a full professor in Murcia, Spain, in nutrigenetics, we looked at a population of overweight and obese individuals undergoing a 20-week long weight loss intervention and asking the question whether their self-selected main meal time, which is lunch in Spain, determines the success of their weight loss. And indeed, we found that those individuals who chose to eat earlier lost about 25% more of their body weight during the same time as those that ate later. We tried to explain this, but we found no differences in energy intake, physical activity, sleep duration as self-assessed, and also fasting, leptin, and ghrelin values. And we're now in the process of or investigating this to understand what the underlying mechanisms of this might be. And then finally, as I mentioned, about 6 years ago, there was a discovery of a circadian-related gene, which is a melatonin receptor gene that is called MTNR1B, that associates with increased diabetes risk. Now, this was discovered in GWAS studies, genome-wide association studies, in which the outcome of glucose is measured during the daytime. It happens to be that during the daytime there is no melatonin to speak of, such that you're studying the effect of a receptor when the ligand is absent. So to counter this, or to address this, we actually studied healthy subjects when we would elevate melatonin. And the question was, what does this do to glucose tolerance as assessed by OGTT, oral glucose tolerance test? And we found a massive effect on glucose tolerance in these healthy subjects, in red here with melatonin on board, indicating that melatonin has a strong effect on glucose tolerance. And then we, in this same study, we could then determine that it's actually this effect is carried primarily by the risk carriers, the top figures, so the risk carriers of this risk variant, and was not significant in the non-carriers. And this is especially important to realize because about half of you are carriers of this MTNR1B risk variant. So to conclude, circadian misalignment adversely affects cardiometabolic health. The circadian system is actually the primary driver for the morning-evening differences in glucose tolerance and beta cell function. Late meal timing is predictive of successive weight loss. And we would suggest some caution with the use of melatonin close to meal times, especially in the 50% of the population who are carriers of this risk gene. And with that, I would like to thank my collaborators, funding, and you for your attention. Thank you.
The way that we wanted to do this panel is after every speaker, just have a few minutes for the other speakers to respond to some of the points. So I thought that we might be able to briefly start with, can everyone hear me? Yeah. Okay, perfect. So perhaps with this one, we could start with Dr. Redline, since you work with patients, and I was curious to know how some of this metabolic work relates to some of the work on sleep apnea that you're doing.
Okay, well, in terms of sleep apnea, as you know, one of the biggest risk factors that we'll be talking about is obesity, and in fact, often patients with sleep apnea have distorted sleep-wake cycles, and one of their biggest problems, in fact, is weight loss.
Right.
So if we think about sort of an integrated approach where we focus on not only keeping their airway open, but really addressing all of their not only the sleep quantity, but when they sleep, I could imagine that this could be a new comprehensive way to help patients lose weight, maintain weight, and breathe at night. And I'm just wondering, as you evolve your work, the other side of this, of course, is that patients with sleep apnea often have diabetes and insulin resistance. Right. And I don't know if you want to speculate the extent to which we might be able to improve that metabolic problem by addressing even some of these circadian issues.
Yeah, no, those are important points indeed. It feeds back, so the concern is that it doesn't just end there. So when people become obese, their risk for sleep apnea increases, which again, we know that sleep disturbances themselves can lead to changes in hunger and appetite. It could lead to increased risk. And the observation of, or the note I wanted to make about patients with diabetes is that in these individuals, the profile of glucose tolerance is inverted, such that actually their glucose tolerance is worse in the morning, which is a very interesting observation which has not been explained and which is something we're looking into as well now. So there is a great interest in trying to make this into a comprehensive investigation.
Dr. Czeisler.
I have two questions. One has to do with findings that that individuals, when looking for risk factors that predict the transition from a high resting glucose or morning fasted glucose that a doctor might see in an office and frank diabetes, that night shift work increases the risk of making that transition by about 500%. And I would presume that, perhaps you could speculate on how this mechanism might be involved. And my second question relates to what Dr. Redline was talking about, because Takeshi Tanagawa in Japan has reported that for a given level of sleep apnea, that the increase in blood pressure associated with that is greater in night shift workers than it is in day workers. And how might these systems be related to that?
I see. Yeah. So regarding the first question, so the increased progression from maybe a pre-diabetic state to a full-blown diabetes state is a very interesting one we're actually looking into now. So we're now studying actually individuals with pre-diabetes to try to understand whether indeed these individuals may be more at risk of showing bigger magnified effects. And this is something that's commonly seen, that in vulnerable populations that are counter-regulatory systems aren't able to compensate anymore. So this is certainly something we're interested in. Regarding the question of increases in blood pressure being more magnified in people with sleep apnea when they're doing shift work, is something that I haven't heard before. So this is something we maybe can talk about later as well. So we have looked at, for example, the role of the circadian system separately from the role of the behavioral physical activity versus the sleep-wake control of blood pressure, where we find a role for each of these components, but haven't studied this specifically in people with sleep apnea.
Great. Thank you so much, Dr. Scheer.
Thank you.
Dr. Redline. Yeah.
So I want to thank the organizers too, but even more so than thanking the organizers, for myself, I like to echo a conversation I had with one of the patients from our sleep apnea patient engagement panel. And we were talking about today, just yesterday, and he just gave me this great big smile. I think he's in the audience somewhere. And he said, well, that's just marvelous that there's a sleep medicine session as part of this wonderful research and innovation day, because that really shows the importance of sleep medicine and the recognition of your institution of its importance and the work that you and your colleagues do. So I thought that was just a nice way to prepare me for sharing with you some of the work we're doing now, which is really trying to do research in a little different way. And in fact, what I'm going to talk about is some of the work in the disease that I've been most interested in, which is sleep apnea, and really sort of our way to pave a new road into finding better answers in a faster and more relevant way. So to begin with, many of you probably have heard of sleep apnea, but just to point out that normally when we go to sleep at night, we really, our breathing is maintained by virtue of having air flow through our nose, through the back of our throat, down into our lungs. However, with sleep apnea, as you could see in the bottom slide, actually the tissues fall back, they collapse, they become very lax, and then we have those obstructions or those snoring or snorting noises. And what sleep apnea, in a very simple way, is when in fact these obstructions occur repetitively at night, preventing the passage of air, causing drops in your body's oxygen levels. That snoring is a manifestation of really turbulent flow through a fluttering airway, and your brain arouses and does not get into good deep sleep, causing daytime sleepiness. And with these episodes, there'll be surges of adrenaline, surges of blood pressure, as Dr. Czeisler alluded to, and actually insulin resistance, which predisposes to diabetes. Now, we all, now sleep apnea, traditionally we thought of sleep apnea as being the fat boy in the Pickwickian papers, and that's shown right in here, meaning middle-aged men who are overweight, particularly who had a big waist circumference. But we know that's an incomplete picture. And in fact, sleep apnea is quite common in women. It goes up remarkably after menopause. It goes up, unfortunately, as we age. It's associated with family members. Our work has shown if you have a family member with sleep apnea, you're between 50% and threefold more likely to have sleep apnea yourself. And even if you're non-obese, other factors such as a smaller recessed jaw will increase risk. And in fact, I think one of the things we're learning is to break down stereotypes, and that's something our patients are telling us, and really understand the large variation in presentation. Now, work that my colleagues and I have done has clearly established, and these are through large population-based studies, that approximately 1 in 5 adults have sleep apnea. And we know as we track this over time, as the population gets more obese, the prevalence goes up. And in fact, some of the work that we're doing in communities across the country show that there's a particular burden of sleep apnea in individuals from disadvantaged communities, in particular children from disadvantaged communities, ethnic minorities, and our recent data focus on Asians and as well as Asian Americans of having a particularly high risk despite a low obesity level. Sleep apnea is also very common in people with other chronic diseases, in particular heart disease, diabetes, and high blood pressure. Now, the reason that my colleagues and I and others are so interested in sleep apnea is because not breathing at night or having recurrent and asphyxia at night and not getting into deep sleep really has a myriad of health and behavior and cognitive effects. And this slide summarizes, hundreds of articles from various people around the world, but it's very clear that sleep apnea is associated with behavioral problems. Cognitive problems, increased risk of accidents, injuries, diabetes, a number of heart problems and stroke, and premature mortality. Now, the exciting part about being a clinician and working with sleep apnea is you can treat it. And there are a number of different treatments. Many of you may have heard of nasal CPAP, and that's a particular mask shown here. But we, in fact, over the last number of years, there are other innovations, including mouth oral devices shown in the lower corner, which simply thrust the jaw open. And both the nasal CPAP or the oral appliance, the point of that treatment is really to open that upper airway space and really stabilize that tube of airflow going in and out. But there's a lot of work, even looking at risk factor management. There's exciting work that just walking every day reduces your sleep apnea severity by actually preventing accumulation of fluid in your neck when you go to bed at night. There are medical therapies that my colleagues in Boston are testing to actually help maintain respiratory stability at night. And there are new surgeries and upper airway stimulation therapy that are all options. And the importance of treatment is that there's very, very good data unequivocal data that treating sleep apnea improves sleepiness, alertness, mental health, and improves quality of life. It increases blood pressure, and on a population basis, actually, this is estimated to reduce a significant number of the strokes out there. In children, there are significant improvements in behavior and attentional deficits. And then there's also suggestive evidence, although those data are still being collected and aren't quite the quality we would like it yet, of reducing risk of heart arrhythmias, or atrial fibrillation, heart attacks, and lengthening mortality. But despite all this work, there are a lot of frustrating things. About 80% of cases of sleep apnea that we find in our epidemiologic studies by going into the homes of people and asking them to wear monitors and showing that they stop breathing 30 or more times an hour are undiagnosed, never been seen or never been discussed and then evaluated by a clinician. And in fact, this disparity is a bit unequal. And in data we just published from a study called the MESA study, which is a multi-ethnic study, only 3% of Chinese Americans with severe sleep apnea that we found on our population surveys actually had a physician diagnosis of sleep apnea. And furthermore, the patients that we work with in our new research, I'll tell you about in a minute, are, note the many, many long delays in diagnosis and treatment, especially for those people who don't meet that stereotype of the fat boy in the Pickwickian papers. So our women and non-obese individuals particularly they get referred to psychiatrists and to a whole host of other doctors before they get adequately diagnosed. We also know that there are challenges to treatment, and there are some groups, and treatment often requires that holistic, comprehensive type of approach that Dr. Scheer and I were just beginning to talk about. And for example, African Americans who often have comorbid insomnia often have very low levels of compliance with these therapies, and those are not explicitly addressed. And this work that I'm talking about has been work that I've been engaged with since I've been age 2 as well, so many, many years, but I haven't aged too much with that. And they include many, many cohort studies. Those are population-based studies around the country of children, pregnant women, middle-aged and older children, older individuals, families, a number of clinical trials and genetic studies. And that's really helped get us to this point, I think, along with my other colleagues, of the slides or the facts I just shared with you, but they're not enough. So just in the last 2 years, I've been getting involved with a new type of research, and it's really a research that the Patient-Centered Outcomes Research Institute, NIH, other groups are really advocating, and it's patient-centered research. And it's really to try to change the way we not only do studies, but design studies and have patients involved at the get-go and all through the process. And really, this recognizes that patients really need to take a leading role in generating that high level of evidence that we need to actually make healthcare decisions, and that we need to actually, to make personal decisions too for them. And we need to actually incorporate things like what are the outcomes of importance to patients, what are their preferences, and how do and knowing that one size, for example, CPAP, is not a fit for everybody. And we also need to know really some of those differences, the phenotype, the genotype, the family history, the obesity levels that actually influence who's going to respond to that growing list of potential treatments I showed about. And we have to understand in any given person, what are those targets that might be most important? Is it their heart? Is it their brain? Is it their alertness? Because some people may be more vulnerable than others. And I think the opportunities of doing research in this way would be to actually improve screening, so we shorten those delays in treatment and we get people earlier in life before brain damage and heart damage have set in. And it's also, with this growing list of treatments, how to choose those treatments in a sensible way, both that would be most effective for the patient and also most acceptable to their lifestyle. And then also how to tailor these treatments based on both biology, clinical aspects, as well as preference. And then finally, to figure out how to improve coordination of care. So what we've done in the last 2 years is built a patient-centered outcomes network for sleep apnea called myapnea.org, and our goal is to recruit tens of thousands of patients and other stakeholders to form a real patient-centered approach to actually support one another, but also to do the research and accelerate what we call comparative effectiveness research. And this is a snapshot from our website, and this actually forum, this website allows people to interact with forums, offer research questions, vote on research topics, access evidence-based research reviews that are vetted by patients and some written by patients, to contribute data online and see your results immediately how it compares to those of everyone else in the network, and access various tools. And just to sort of summarize, a different way of creating a research pipeline is shown here, where our patients themselves rank the research questions, nominate research questions, and vote on them. They then discuss them in a forum. We then do evidence-based reviews, and then we catalyze projects. And to date, we actually have about 5,500 members, more than 38,000 online surveys completed, 1,800 votes on research topics, and we're actively designing new studies. One of our patients is leading, for example, a new survey to identify those women and non-obese people. So at this point, I'd like to just thank my staff, our steering committee, and especially our patient engagement panel. Thank you.
Thank you. Thank you, Dr. Redline. So we're running a little bit over, so I was wondering if we might have just one reaction rather than from both of you, since Dr. Czeisler, if you'll be speaking next, so perhaps Dr. Scheer, you can respond to, I was quite interested in the connection between the genetics and the behaviors and have the interplay of those two, and there seems to be a lot of overlap with what you're studying genetically and what Dr. Redline is trying to figure out in terms of those two predispositions.
So I guess that's a question from you.
It's a question from me to kind of to prompt you.
Yeah. So we're actually
different question, but yeah.
No, well, why don't you ask your question, please?
Sorry. Well, my question was, if you have any, so as you indicated, the underlying mechanisms for the phenotype of sleep apnea can be very diverse. So the underlying reason, why does somebody have sleep apnea? And what are your views on trying to design the best approach of treatment based on the underlying mechanism, and how you actually come up with screening somebody sufficiently in order to guide your therapy?
Yeah, that's a terrific question, and there are two approaches. So I think one approach is really a big data approach. That's our approach with myapnea, and then basically by getting a lot of information on people and following them over time and using statistical techniques, including biomarkers, which we hope to collect even through the mail and saliva, we'll be able to cluster people into more biologically relevant groups. And then the other would be the approach that some of our colleagues in the division take, which would bring in, individuals who are very intensely phenotyped and really try to dissect those aspects of breathing stability versus upper airway occlusion, and then actually try to find markers that could be applied in the clinic.
Wonderful. Thank you so much.
Sorry.
No. Dr. Czeisler.
Is this, let's see if this is connected. Okay, Dr. Redline, thank you very much for the invitation to speak here today, and thank you very much to the organizers. I'm really going to talk about, based on the framework that you've already heard from Dr. Redline and Dr. Scheer, talk about the impact of this, what can only be described as an epidemic of sleep deficiency that is in our society. We are all facing increasing pressure to try to sort of burn the candle at both ends as we try to succeed and we try to meet the demands of our work schedule, the demands of children, the demands of caring for older adults, and so on. And so often we find ourselves sort of entrapped in sort of a treadmill in our 24/7 society in which the machines are expected to be functioning 24 hours a day, 7 days a week. And somehow we are put into that same boat. And so an increasing number of people find themselves exhausted. And 70% of Americans say that they don't get enough sleep on a regular basis. And some people say, well, we don't need as much sleep as we used to. So the fact that we're sleeping an hour and a half less today on average than we did 50 years ago here in the United States, people are like, well, that's because there was, I've actually, at one point, I gave this statistic to a group of NBA players, and the star player said, that's because back then there was no blank to do. Basically, I can't quite quote him exactly, but there was nothing to do. And I did have to point out, the TV stations went off at 11:30 or 12, and we just had a screen. After the flag flew, there was just sort of fuzz on the screen, so there wasn't as much to do, and I would concede that. But to those who say we don't need any more sleep, I point out that there are 56 million people a month who report that they are struggling to keep their eyes open while they're driving. 8 million people a month lose that struggle and actually admit to falling asleep at the wheel while they're driving. And that results in nearly 1 million motor vehicle crashes annually, over 500,000 injuries associated with those crashes, and 55,000 debilitating injuries and 6,400 deaths annually. It's responsible for 1 out of 5 motor vehicle crashes in the United States, drowsy driving. So it's a huge unmet medical need. And people also don't, the people say, why do undergraduates in a class that I teach every week, they're like, well, if you could give me a pill that would make it so that I was not sleepy, because really, when you come down to it, the only reason why people go to sleep is because they are sleepy. It's to relieve sleepiness, to avoid that feeling. So if you could get a pill, and of course, most everyone, I don't see too many Starbucks or Dunkin' Donuts glasses. I see they were not allowed in here. Fantastic. But yeah, and of course we do take a lot of caffeine. Just in soft drinks alone, 10 million pounds of caffeine are loaded into them every year in the United States. It's a fantastic number. But people say that even if people knew that it was critical for memory consolidation, Harvard undergraduates say if I could take a tablet and I would never feel sleepy, I wouldn't sleep. It's like, and I said, well, but what about the functions of the brain and so on? And they say, well, we're supposed to exercise. We don't do that. We're supposed to have a good nutrition. We don't do that. If we didn't have to sleep, we wouldn't do that either. But it is key for memory consolidation. So the things that you learn during the daytime, they're actually consolidated, and we rehearse them at about 20 times speed during the night in deep, slow wave sleep. And then later on and later on, we rehearse those when we go through them again in rapid eye movement sleep, when we integrate them with our previous memories. Now, in addition to that, the brain burns a tremendous amount of energy. It's only about 1 to 2% of the weight of the body, but it burns about 20 to 25% of the glucose and the oxygen that we consume, because firing those neurons takes a lot of energy. It also, like any, despite the fact that it's a LEED certified, very green furnace that we have up there, it still produces metabolic debris, and it still results in the buildup of toxins, and there's still damage associated with that. And we do run out of energy. And so we need to replace that energy in order to maintain our focus, attention, and alertness, as I said, integrating with prior experience. So we have to replenish those energy stores, which takes place during sleep. And it is not replaced by just taking caffeine. which simply mucks up the sensor that tells the brain whether or not you are tired. So this is changes in brain energy use during the day, and you can see that if you're awake for 24 hours, these areas of the brain, critical for judgment and control, sensory information, areas that relay sensory information to the motor cortex and the visual cortex, they're all running on E. The blue is when they're not burning energy at the right rate. They're cold. It's like they're stone cold, like an engine. And yet we're still asking the brain to perform. And it's another thing that is very exciting is that it's now recognized that not only pruning unnecessary connections, but also repair of damage takes place during sleep and clearing of toxins. So a woman by the name of Macon Nedergaard discovered several years ago these channels, these pores in the brain. We don't have a regular lymphatic system in the brain like we do in other parts of the body to drain away toxins. But we have sleeves around the blood vessels in the brain, going all the way to the arterioles and to the venules and so on. And these sleeves are where the cerebrospinal fluid flows in what she called a glymphatic system, as an homage to the lymphatic system, which drains these toxins out of the brain. And amazingly enough, during sleep, the cells in the brain shrink and these glymphatic channels enlarge by about 60%. It would be as if in New York the buildings shrank and the alleys got bigger and the sewers got bigger, so we wouldn't have to climb over all that garbage during the daytime like I had to do 2 weeks ago that is not cleared off of the streets. So, and that's what happens in the brain. And what are some of these toxins that accumulate? They're toxins like amyloid beta. And we all know that if amyloid beta builds up and is not cleared out, it forms plaques that are associated with Alzheimer's disease. But it's not just the brain, but also the body needs sleep. We've already talked about how blood pressure increases if individuals have not gotten enough sleep. And even Dr. Redline has shown that even teenage girls, their blood pressure will increase if they haven't gotten enough sleep. In addition, resistance to infection. It's the flu season. We're all supposed to get a flu shot now. And if you haven't been getting enough sleep in the week before you get the flu shot, you only have half the antibody response during the first week after the shot than you would have had if you were getting an adequate amount of sleep before you got that shot. We also catch cold. We have a 2 to 3-fold increased risk of catching a cold if we're inoculated with the rhinovirus if we haven't been getting enough sleep. As Dr. Scheer pointed out, sleep is critical for regulating appetite and metabolism. I'll just add one little note there that if you are on a diet and you're only getting 4 or 5 hours of sleep a night, and you're on the same diet, you're killing yourself with the same diet. But now you're comparing yourself with somebody who's getting an adequate amount of sleep. When you're sleep starved while you're on that diet, 3/4 of the weight that you lose, everybody loses the same amount of weight, 3/4 of the weight that you lose when you're not getting enough sleep is in lean body mass and not in fat. How crazy is that? Because the brain, animals don't stay awake at night unless they're starving, unless they need to forage to get food. And so the animals, so somewhere in evolution, sleep and metabolism got linked. So the brain goes into starvation mode where you're squirreling away all the calories you're getting into fat if you are not getting enough sleep. Frank has already talked about insulin effectiveness. But our mood is also affected. We become more emotionally labile. And this is one of the things that I'm most concerned about when it comes to kids. Susan Redline alluded to this. About how our attention deficits become worse if we're not getting enough sleep. Now, kids have lost more sleep as a group than any other group in our society. They're sleeping about 2 hours less per night on school nights than they did several generations ago. And we have an extraordinary number of children who are now being diagnosed with attention deficit hyperactivity disorder. And unfortunately, the symptoms of sleep deficiency can masquerade as ADHD in children who are not getting enough sleep. And so the fact that 1 out of 5 high school boys in the United States are diagnosed now with ADHD is kind of shocking. And really it was Dr. Stuart Kwan, who's in the audience, who first educated me about the fact that sleep deficiency in kids mimics the symptoms of ADHD. And yet, we have industries, entire industries. The gaming industry is boasted that kids are now spending 3 billion hours a week video gaming, much of it happening after the parents think that the kids have gone to bed. And their goal is to bring this to 20 billion hours a week by 2020. So we've talked about all these different health consequences, including increased risk of depression and emotional instability. I just want to end by framing some of the data that Dr. Redline talked about, which is that people with persistent insomnia that are not treated, and this is data that Dr. Stuart Kwan and others recently published, have a 65% increased risk of mortality over a 20-year period. So it does affect mortality. And if we look at sleep apnea, those without sleep apnea started being studied at age 48. And unfortunately, at the time this study was started, the sleep field made one of the biggest mistakes that we can understand in retrospect. But at that time, patients were told that if they weren't sleepy, and over 80% of patients with sleep apnea don't report being sleepy during the daytime, if they weren't sleepy, they should not be treated. That was the recommendation, even as recently as earlier this year in the major textbook of internal medicine, until Susan rewrote that chapter. So that gave epidemiologists a chance to follow along what happened when they followed the doctor's advice. And those without sleep apnea, 94% of them were alive by the time they were at age 66. Those with untreated severe sleep apnea, only 58% were alive. Very sad, very chilling. But I view this, now that those data are available, although one could view this as pessimistically, I view it optimistically. Because we really, and as Susan mentioned, of those who live, they get cognitive impairment 10 years earlier and Alzheimer's disease 5 years earlier. So I'll end with Benjamin Franklin's comment, they'll be sleeping enough in the grave. You will get there a lot more quicker if you don't get enough sleep. But I view this optimistically because we now have this knowledge, and sleep is one of the easiest things that we can pay attention to, make a priority, and improve our health, wellness, performance, safety, mood. I mean, what other thing can you do that has such a major impact? So thank you very much for your time and attention.
Does anyone in the audience want the pressure of the single question? Yeah? Please.
This is the big question. What should we do on a day-to-day basis to improve our sleep and improve our quality of life?
It's a great question. Panelists.
I'll just take a shot at it. There are three key factors. One is the duration of sleep. So the average adult needs 7 to 9 hours of sleep a night. So if you're trying to burn the candle at both ends, only getting 4 hours, that's not going to work, even if you're applying yourself with as much caffeine as you might need. The second is timing. So as Dr. Scheer pointed out, consistency in the timing of when you sleep is also very important. And trying to go to bed and wake up at approximately the same time each night. And then the third, of course, is quality of sleep, and that's where Dr. Redline's work with sleep apnea and other sleep disorders is so critical.
Dr. Redline, do you want to comment?
Oh, I think the challenge, I think Dr. Czeisler said that really well, and I think one of the challenges is we all make trade-offs. And I think it's, do we exercise, or do we sleep, or do we work, and I think this is in fact where, the first issue is to recognize that sleep is that one of those pillars of health, and that you really can't ignore it. And then I think people do need to think very thoughtfully how they balance their entire lifestyle, around, health habits that do include exercise, diet, sleep, and some of that and also stress. So I think these all are intertwined, and I think the first thing is to recognize that it's important.
Yeah, so I think most directly to your question, what should you do? I think it's thinking about sleep hygiene is kind of the first basic thing you can do, and these are all over the web. And the problem is most of the time we know what to do, we just don't do it. But I think regularity of sleep timing is something that's more achievable and you can be more conscious of. And of course, weekends are a great problem, especially your Monday mornings, you'll recognize as a problem, and because you've been delaying your bedtime, delaying your wake time. So my kids, for example, I have them wake up and go to bed every day the same time, and well, they're young, but they still have very good sleep. So we'll see in about 40 years or so. And of course, caffeine, as it relates to what Dr. Czeisler said before, not only does caffeine help you stay awake during the day, it also helps you stay awake during the night. So this is an obvious one you can think of, and there are many more, but I'll keep it at that.
Frank, I have one question for you. Let's say you work in a hospital. And the patients have to be and the patients have to be cared for at night. What do you recommend to people?
Right, right. No, so this is the difficulty, and so our interest is especially into food timing. So I think shift work will never go away. We'll have always shift workers. There's certain things we can't automate. So we'll have to be awake during the night. So things that we can modify are when we eat. And I think that's why, and this is a key behavioral aspect, we can actually wrap our hands around and modify once we know exactly what to do. So this is what our group is having a big focus on.
Perfect. Thank you all so much. I think this was an absolutely fascinating panel. And now I hope you will all go to bed early.